Apart from that, there are other forms of treatment which my next colleague, Dr. Amit, will discuss. Now, if I want to include the radiation as a modality, then my treatment should, whether it should include nodes or only the prostate. Now, if I want to include the nodes, the nodal radiation treatment portal should be based on the vascular rather than the bony anatomy. Now, if I am including the nodes, these are the nodes which I have to include in my treatment portal. And one thing which is very interesting, if we see the radiation trials itself, different trials have different superior borders, and that can be the reason why we could not get the adequate results what we wanted. And if you look at the PAW party trial by Dr. Vedang Murthy sir's group, they have included the superior border at L4, L5, and by that process they could include at least 93% of the lymph node, and that could be the reason that their trial is positive in the terms of the endpoint what they wanted to look at, whereas the other landmark trials like RTOG 9413 and GETAC-01 were the negative trials. Now, what to treat? The question is whether prostate only versus whole pelvic radiation therapy. Now, this is a subject of controversy, and elective lymph node radiation is controversial. And why it is controversial? Because it could not mend the end point, that is overall survival benefit. But overall survival benefit could not be achieved. Probably it could be the reasons like selection of the patient, the technology, the volume, the dosing, and other so many factors which could be also attributing to the results. Now, to answer this, this positive trial, that is PAW party trial, which everybody is of us being radiation oncologists are proud of from our country, from Dr. Vedang Murthy sir's group, where the comparison was simply whole pelvic RT versus prostate only RT, and the end point was biochemical failure-free survival. And what the conclusion came was whole pelvic RT is significantly better than prostate only RT in the terms of biochemical failure-free survival and disease-free survival. It was very interesting to note that though overall survival was not significantly different in both the groups, but the median follow-up is only 68 months, and we do hope that in the due course of years, even overall survival curve might improve. That's for game. Should radiation boost to be given to the involved nodes? Again, this is a matter of controversy, but still the radiation dose escalation to positive nodes is definitely advisable because it does improve the relapse-free survival and distant metastasis-free survival. And we do know that distant metastasis-free survival can be a surrogate of overall survival in the due course. And even NCCN guidelines and the Australian and New Zealand guidelines do advocate that if there is a lymph node positive, at least 60 gray or even more than that should be given to the positive lymph node. Now coming on to the androgen deprivation therapy, what should be the duration? We don't have a randomized controlled trial which says that what should be the duration as such, but radiation with long-term EDT is definitely recommended in the node-positive patients. And the subgroup analysis from the Stampede trial by James et al., it did mention that if we add ADT to radiation, it shows a better failure-free survival with addition of ADT along with radiation. Even a systematic review from the European guidelines did mention that ADT with radiation has a overall survival and disease-specific survival benefit. What about the fractionation, conventional versus moderate hypofractionation? Again, it is a proud that Dr. Indranil Malik and Moses Arun Singh both are here. And from their prospective study, they did see that moderate hypofractionation radiotherapy is definitely, it's established for along with long-term ADT for node-positive prostate cancer patients. So it is definitely, it is feasible as far as moderate hypofractionation is concerned. Coming on to the, what about the role of extreme hypofractionation? Again, Dr. Vedang Murthy's group, sir, has, they are conducting this prospective trial, that is PRIME trial, which will be comparing the moderate hypofractionation with extreme hypofractionation, and in the due course of years we'll be getting this. And this trial is indeed special because this is a trial which is looking into for the high risk and the node positive patients too. That's something important. Now, what about the duration of ADT for high risk and node positive cancer patients? If you look at this long-term trial published in Lancet almost a decade back, that is EORTC trial, it did come to a conclusion that at least 3 years of ADT will be beneficial in the terms of disease-free survival and overall survival. Coming on to the RTOG, again 20 years of follow-up published almost 5 years back, 6 years back, which compared two arms, that is 4 months versus 28 months, and they did say again that longer ADT is definitely superior to the shorter ADT. Even the ESTRO-ACROP guidelines, which was published in January, February this year, it did say that patients with having a high-risk features will benefit from abiraterone and prednisolone for 2 years, plus ADT for 3 years, and radiation, and that should be the new standard treatment for high-risk prostate cancer patients. Coming on to the role of abiraterone in improving outcome. Now, why did it come? Because high-risk CA prostate is being treated by radiation and ADT, but despite that, post-treatment failure rates remains to be high. And metastasis-free survival, we all know it is a surrogate of overall survival. Now, when in this particular trial of a subset analysis, a meta-analysis in which ADT plus ADT with enzalutamide along with radiation was when abiraterone was added, there was an improvement in metastasis-free survival, overall survival, prostate cancer-specific survival, and even the progression-free survival. So this particular trial, which is a meta-analysis, it did say that 2 years of abiraterone and prednisolone added to ADT and radiation can be the new standard of care. That is, along with EBRT plus ADT plus 2 years of abiraterone plus prednisolone will be the new standard of care probably. So to conclude, high-risk non-metastatic prostate cancer, ADT with radiation will improve metastasis-free survival, and in due course it will improve overall survival. 2 years of abiraterone and prednisolone added to ADT and RT can be the new standard of care. However, Dr. Indraneel did mention about the role of PSMA PET in the morning. So advances in imaging and delivery technique will allow dose intensification, specifically at the sites of gross disease, while minimizing the toxicity and even improving the quality of life. Thank you. Thank you so much.
Thank you, Dr. Tanveer. We can now have the next speaker, and then we can have the discussion. Dr. Rahul Jaina, who is a senior clinical fellow in uro-oncology and assistant professor in urology at AIIMS Royal Marsden NHS Foundation Trust, Jodhpur. Over to you, sir. You've got 8 minutes.
Thank you. When I got this topic, I initially wanted to present it as a debate between whether you would choose radical prostatectomy or radiotherapy for locally advanced prostate cancer. But then as I went into the topic, and also because I realized Ms. Tree will be here, I did not want to get ahead of myself. She's a senior colleague at the Royal Marsden. I realized that you cannot do surgery without the support of a radiation oncologist. So no one actually knows what is the optimal treatment of locally advanced prostate cancer. But we do know that most of the published items, they say that external beam radiotherapy and androgen deprivation therapy is the treatment of choice with the best published oncological outcomes. But if we look at this meta-analysis, this examines all that data, and it tells us, the only thing it tells us scientifically is that local treatment with systemic treatment gives you best results when compared to local treatment alone. And in most of these studies, this local treatment was radiation therapy. There are no randomized control studies examining radiation therapy versus surgery. So the optimal treatment in scientific terms as a comparison between these two is still unknown. And any of these treatments is always part of a multimodal approach. Now, to answer this question, we have something which is going on the Scandinavian Prostate Cancer Group. This is a randomized controlled trial comparing surgery to radiation therapy and androgen deprivation therapy in this very setting. Recently, they have published results of feasibility of implementing this trial. They have recruited 800 patients out of the 1,200 that is the sample size. Now, how to achieve best results with radical prostatectomy? It always has to be part in locally advanced prostate cancers. It always has to be part of a multimodality approach. And NCCN even says that this is an option, initial option for young and fit patients who are not fixed to the pelvic side wall or do not have enlarged lymph nodes. And studies show a cancer-specific survival of around 87% at 10 years. So the outcomes of RP, the best outcomes of radical prostatectomy, can be oncological outcomes or functional outcomes. So for functional outcomes, patient selection is very important. Younger patients, you choose radical prostatectomy because you can potentially avoid them getting hormone therapy, fit with a good performance status, especially patients who have bladder outlet obstruction with severe lower urinary tract symptoms can benefit from radical prostatectomy as an initial treatment, and those who are motivated to carry out functional and sexual rehabilitation, or in those patients who have a contraindication to radiotherapy, you can choose radical prostatectomy. For that, you need to do a good staging. Multiparametric MRI will help you to plan nerve sparing, and studies have shown that planning a surgery using a multiparametric MRI also leads to lower rate of positive surgical margins. You can predict the recovery of continence by seeing characteristics such as the membranous urethral length and the membranous urethral width, the sphincter volumes from this multiparametric MRI. I'm in the process of publishing a paper on 2,000 patients of membranous urethral length. And for distant staging, you can use a PSMA PET scan, although since morning, a lot of us have gone over this a lot of times. There is the Will Rogers phenomena to consider where you have the lead time bias and the stage migration, but still I would advocate that we use this in staging of high-risk, locally advanced prostate cancers. And in some centers, such as the one where I'm a fellow at, the findings of PSMA PET scan are even used to guide whether you do a lymph node dissection or not while doing a radical prostatectomy. Now, when you're doing a radical prostatectomy for a locally advanced prostate cancer, be very sure to stay outside. If you have a locally advanced prostate cancer on both sides, be very sure to stay outside the Denon-Villiers fascia. And you can omit the nerve sparing. That would probably help you achieve a good oncological margins. Or this is something which is being tried out. The feasibility has already been published. This is the NeuroSafe protocol, whereby you do a radical prostatectomy, preserve the nerves, and then you examine the sides of the prostate by means of a frozen section. And if you find it coming close to the surface of the prostate, you go in and you excise the nerve bundle on that side. The extended pelvic lymph node dissection that you should do should be should have the following boundaries: the external iliac vein laterally, the internal iliac vessels medially, and caudally up to the obturator nerves. So in the era of PSMA PET scans, is doing an extended pelvic lymph node dissection actually justified? I think yes, and the guidelines also say the same thing, because they have been shown to have an advantage in the biochemical recurrence-free survival, especially in the high-risk patients. It is the most reliable staging method because you're actually seeing the tumor under the microscope rather than a signal on a PET scan. And if you have pathological confirmation of lymph node invasion, you can start adjuvant therapy early. The oncological outcomes after radical prostatectomy can be positive margins, persistent PSA, and biochemical recurrence, which happens in up to 1/3 of patients of PT3 plus or minus positive surgical margins. And after making this slide, I changed it from a debate because the next point involves radiotherapy. Without doing radiotherapy, you cannot hope to achieve good outcomes for these patients. And the EAU recommends that all patients with ISUP 4-5 with positive or locally advanced tumors should have intensity modulated radiotherapy. And it should be a shared decision making about whether to have salvage radiotherapy or not. And if you have node positive patients, you offer them adjuvant androgen deprivation therapy. Now, whether to give adjuvant or salvage radiotherapy, we have 3 trials, all of them very good trials: the RAVES, the Radicals, and the GETUG AFU. All of these trials have shown that the majority of these patients could avoid adjuvant radiotherapy, and it has the advantage of having a lower GI and genitourinary toxicity with salvage radiotherapy. Now, talking about neoadjuvant androgen deprivation therapy, yes, it's a hot topic. Yes, CDs have shown that there is downstaging of locally advanced tumors, which makes surgery better. But Overall survival outcomes have not been proven to be better. In fact, some studies have shown them to be worse. But then I don't think overall survival should always be the best marker to guide us. And if we have upcoming data which shows that this is beneficial, then this will definitely be something that we can do in the future. Now, the advantages of choosing radical prostatectomy as an initial treatment. So it's already being used worldwide as an initial treatment of locally advanced prostate cancer. That was the very reason that there was no uniformity in the treatment allocation, and that's why they could not come out with a randomized controlled trial comparing radical prostatectomy with radiotherapy earlier. Now the Scandinavian group has managed to overcome that. So young fit patients with LUTs and bladder outlet obstruction and contraindications to radiotherapy should definitely benefit from this. They may avoid the side effects of radiotherapy. You may decide to just observe them without, if you achieve reasonable cure with surgery. Most of them will almost always avoid the effects of hormone therapy. If you were to choose this patient for radiation therapy as a first instance, then you would definitely supplement it with hormones. But if you have, let's say, positive surgical margins after doing a radical prostatectomy for a locally advanced prostate tumor, you may not require hormone therapy in all patients. And radiation therapy is always an option after surgery if the patient ever fails. And I'll just take 1 minute. Professor Chris Parker, who published the Radicals trial, he's a senior colleague of mine at the Royal Marsden. I came to him to discuss the Radicals trial, and I told him, sir, your trial shows that most patients do not require adjuvant therapy, and they can be managed later by salvage radiotherapy. Does it mean that all patients of locally advanced prostate cancer who come to us, we can do radical prostatectomy in them? Because you have shown that should they have positive margins, they will anyways not require radiotherapy. We can easily cure it with salvage radiotherapy. He's a very kind gentleman, but he was horrified that I could deduce this from his study. So the point remains that no paper, no guideline is going to tell you what to do. So we should not be blind in deciding that I'm going to give radiotherapy for this patient, I'm going to give radical prostatectomy for this patient. We have to decide it on a per patient basis. Thank you.